Hello, my name is Frank McMahon. Today we're going to discuss how to do a patient assessment. It's pretty long, pretty intense, but the trick to it is really to break it up into parts.
Patient assessment may seem complicated. It helps to break it down. There are 6 components. By learning the steps to each component, you will master the skills that make up patient assessment. The first component is scene size-up. The second component is the initial assessment. The third component is the focused history. In the case of a life-threatening scenario, you will skip the focused history and move right into the focused physical examination. This is a rapid assessment and is often associated with load and go scenarios. If the situation is not life-threatening, it is time to move to the 5th component, the detailed physical examination. The 6th and last component is the ongoing assessment. Let's listen to Mr. McMahon describe the first component, scene size-up.
The first assessment is called the scene size-up. So you're kind of sizing up safety of you and your partner, which is imperative. If you get injured, you become a part of the problem. So the scene size-up has about 5 or 6 components to it. The scene size-up is really done basically on a visual assessment, of which you visualize the whole scene to make sure it's safe. You have body substance as far as isolation or precautions. You see that there's one victim or multiple ones, which means then you need some additional resources. If you just see one victim, you're kind of looking at the MOI, the mechanism of injury. So if you see a skateboard, or if you see, say like a baseball bat, or you're out in the baseball field, a football field, you can probably assume that there might be some type of head injury, neck injury. You might have your partner whole C-spine.
Scene size-up can be broken down into 6 parts. 1. Body substance isolation. 2. Scene safety. 3. Nature of illness. 4. Number of patients. 5. Additional resources. And 6. The necessity for C-spine precaution.
When you really get into the patient assessment, it's really a type of like an initial assessment of life-threatening situations. Is this a situation where I need to load and go? This whole like initial assessment should start off and end up within 2 minutes. So from the initial assessment, you're really moving into the airway, breathing and circulation, severe bleeding, and then respiratory and oxygen therapy. So if he was unconscious, then I'm going to go right into the initial assessment of really the ABCs. I do a chin lift head tilt, look, listen, and feel for the breathing. If he's conscious, I can see that his eyes are open. I can see like the skin, and it's not cyanotic blue. And I'm watching, the breathing. So I'm doing, these multiple tasks all at the same time, while my partner is behind and holding C-spine and C-spine precautions. Also, you want to be thinking about when you look, you observe, you can also kind of visualize, is this a mild or moderate or severe? Do I need to load and go? And obviously when you're doing the ABCs and you shake and shout, you're checking the mental status. You want to see if this person, like I said before, is conscious or unconscious. So the mental status is really done by the AVPU. So the AVPU, if you remember, is the person alert? Their best verbal? Are there any pain? Or are they unconscious? / unresponsive. So that's really the initial assessment.
The initial assessment can also be broken down into parts. First, the ABCs. Second, pulse. Third, chief complaint. Fourth, impression of the patient, mild, moderate, or severe. 5. Responsiveness or level of consciousness. Remember to use the acronym AVPU. 6. skin signs. Let's now look at the focused history.
The sample is your signs and symptoms, of which that's from the chief complaint. You'd go through the O, P, Q, R, S, T. The O is the onset. When did this happen? The P is what provokes, what causes this to hurt more, even to what makes it feel, like a lot better. The Q is the quality. Is it a sharp? Is it a dull pain? Is it constant? Is it intermittent? The R is, does it radiate, which means does it move down the arm or say like up the arm? The S is really the severity. So you want to ask people in a 0 to 10, 10 being the very worst pain, 5 being right in the middle, 1 being very little pain. So we want to find the severity, and then of course the T is for the time. Getting into the sample, the A is the allergies. So if he was conscious, I'd want to know if he was allergic to anything. The M is, of course, really the part of medicine in that does he take any pills, and a lot of times it keys the medic into if he's on a certain pill, that might be the cause of what the problem is as far as the medical history. So for example, if the person is taking blood pressure medicines, maybe the blood pressure is too high. So getting into the P, the past medical history, it also can be considered pertinent medical history also. You don't want to talk about medical history when he was 2 weeks old or she was 2 weeks old. You want pertinent type of information that maybe happened within about a week or so. So the next one is last oral intake. That's the L. And the reason why you really want to ask that is because you want to see if there's any food / sugar. So the person might have some type of altered mental status because they're low sugar. And then of course the E, the events leading to this is also very important. So in really the second section, you're kind of really finding out more medical history and more about the chief complaint.
There are 2 acronyms commonly associated with the focused history, OPQRST, and SAMPLE, SAMPLE. By using these 2 acronyms, the EMT can gain valuable insight into the patient's condition or situation. The EMT can also rule out a number of different situations. For example, in SAMPLE, S stands for signs and symptoms. But when the medic gets to allergies, A, he or she can rule out allergic reactions. M stands for medication. Rule out overdose or medical history. P, past pertinent history. Rule out repeated problems. L, last oral intake. Rule out low blood sugar. E, events leading to the problem. Rule out trauma or rule out possible cause of problem. Remember that if at any time during the focused history you determine the patient is experiencing a life-threatening illness, stop the focused history and move directly into the focused physical examination. The focused physical examination can be done rapidly and is often associated with the load and go scenario. Let's listen to Mr. McMahon talk about the focused physical examination.
You want to actually put your hands on. You want to take the vital signs. You want to move into like the vital signs. So I have, like a BP cuff. I would very often have maybe my partner or a firefighter take maybe the blood pressure, possibly on the opposite side. And with the vital signs, you want to review the mental status. You want to review the respiratory status / oxygen therapy. You want to take the pulse, and you want to take the blood pressure to include skin signs. And of course, skin signs, when you do take a pulse, you very often can tell if the person's skin is cold or warm or hot.